introduce you to a little robot voice gets me every time. Okay, Dr. Chelsea's okay. She is an associate professor at the Department of Population Health Sciences at the University of Utah and the Center for Health Outcomes and Population Health at the Huntsman Cancer Institute and the University of Utah. Her research and interests include implementation and dissemination of evidence-based practices for cancer control and prevention into community and healthcare settings that serve historically disadvantaged populations. Her work has focused on developing and evaluating the effectiveness of clinic and patient-level interventions to improve implementation of evidence-based practices into clinical settings and partnering with community settings such as schools, childcare, parks and rec, and Girl Scouts to characterize youth physical activity and evaluate implementation of evidence-based practices for improving youth physical activity. So without further ado, please help me welcome Dr. Chelsea Schlepper. Thanks so much for inviting us to come speak today. It was really exciting.
Excuse me, we can't hear you if we're remote.
Okay. Are we unmuted?
Yeah, we're unmuted.
Okay. Can you hear me now with the remote or with the microphone?
Yes, yes.
Maybe I can come.
Okay.
I'll speak louder. How about now?
Yes, thank you.
I have a quiet voice, so I will try very hard to address today while we're speaking. So my talk today is focused on some of the work that we're doing at the Center for Health Outcomes and Population Equity at the Huntsman Cancer Institute in the University of Utah. As Star mentioned, I'm an assistant professor in the Department of Population Health Sciences and at the Huntsman Cancer Institute, and I'm also an investigator in the Center for Hope. That's a great question. Is it on? Okay, I can have a light. Maybe it needs to click over here.
Can I make the comment? I don't think it's the volume of your voice. It's something to do with the microphone. They briefly had it on and we could hear you loudly and it disappeared again.
How about right now?
Yes.
Okay, perfect. I will try to speak loudly and please interrupt me if you can't hear me or if you have any questions. Feel free to interrupt at any time. So today I'm going to go through a brief introduction of what the Center for Health Outcomes and Population Equity, who we are and what we do at the Huntsman Cancer Institute. I'm also going to talk briefly about our partnership approach for how we do our work to try to improve implementation of evidence-based interventions into different healthcare and community settings. I'm going to give a few project examples. We have quite a few ongoing projects, and I'll just focus on a couple of those today. And then finally, I'll talk really briefly about some lessons learned we have in our work with partnering with community partners to implement evidence-based practices for cancer prevention, chronic disease prevention, and recently with COVID-19 infectious disease prevention. And then I'll also talk about some future directions that we have. Okay, so in brief, the Center for Hope, we're a center at the Huntsman Cancer Institute, and our goal is to serve as an infrastructure that bridges research and community engagement. So we're really focused on using community engagement principles, focused on sustainability, and also having a population health impact. Our mission is to bring together communities and researchers to create long-term solutions to prevent cancer, chronic disease, and infectious diseases. And we do a lot of our work among underserved populations. Our overall vision is to have equity in cancer and disease incidence, morbidity, mortality in Utah and across the Mountain West. Our major research foci are on health and equity, so we partner with communities that serve populations that have been historically marginalized. We focus on implementation and dissemination of already existing evidence-based interventions. We do some development of behavioral interventions, and we partner with low socioeconomic status, racial ethnic minorities, and rural and frontier populations for this work. And then finally, we also have a training mission. So we train scientists to be the next generation of scientists to help improve health inequities. So our guiding principles, overall, we want to make a real world impact. We do that by using translational science, transdisciplinary science, and we rely heavily on team science. We know that in order to make an impact, it's not just us. There's many people out there that we need to accomplish our goals. We collaborate with academic institutions in Utah, across the Mountain West, across the US and globally. And we also focus a lot on community engagement. We partner with the communities that reach the populations that are most in need. We do all this with an integration of research, education, and service. And our culture at the Center for Hope, we seek to be collaborative, transparent, and caring. And we came up with some shared values at one of our retreats a couple of years ago. And we really try to see and seek the good. We focused on our trust, communication, and overall to have a passion for the work that we're doing. So again, just touching really briefly on our areas of research. So we focus on discovery. So we try to understand what are the causes of human behavior and understand what influences engagement in health behaviors like tobacco cessation. We also focus on developing interventions and testing interventions that are based on theoretical models for what influences human behavior. And then today what I'll talk about a lot is that we're also focused on implementing and disseminating evidence-based interventions to try to improve health behavior. So all of the work that we're doing really relies heavily on a partnership approach. In Utah, we built this astounding partnership with the Association for Utah Community Health, which is the primary care association in Utah, the Utah Department of Health and Human Services. They recently changed their name, if you don't recognize them. The community health centers throughout the state of Utah. So we have 14 independent community health center systems. And then we have our partners at not only the Huntsman Cancer Institute, but across the University of Utah. So why are we partnering with community health centers? In Utah, there's over 60 clinics and they serve over 165,000 individuals each year. And they serve patients regardless of insurance status. They have a population of patients that are racial and ethnically diverse. So almost half are Hispanic or Latino, 9% are American Indian or Alaska Native, 66% are at or below the federal poverty level, and almost half are uninsured. And we also have a big focus on rural and frontier clinics. So in Utah, 39% of their clinics are in rural or frontier counties. So partnering with these individuals allows us to reach populations that have been historically marginalized and are in need of interventions. Some key characteristics of our partnerships we found out over the years. Number one is that we seek to have shared goals and values. So the projects that I'm going to talk to you about today have all come up because they're shared priorities of our community partners that we're working with. And we've taken those priorities to then try to match our research skill set to, in order to either secure research funding and then conduct research projects, or to bring in new partners that have the academic knowledge that we may not have in order to address our community partner priorities. We also seek to respect the expertise of everyone that we participate with in these partnerships. So for example, we've established patient and study advisory committees that consist of representatives from our community health centers that we work with, patients of those community health centers, representatives from the Primary Care Association, the Department of Health and Human Services. We have weekly meetings with our stakeholders from these different partners so that we are on the same page with all of the projects that are ongoing and future projects that are coming down the pipe. And importantly, we also have an embedded Primary Care Association team member at the Center for Hope. So Tracy C. Paris is in the red jacket in that photo. And she's actually a employee of the Primary Care Association and has been for a number of years. She was also a medical assistant at one of the community health centers prior to joining the Primary Care Association. And she has a great working relationship with each of the community health centers. So she is actually funded partially as an employee for the Center for Hope, as well as the Primary Care Association. So she is embedded with all of the CHCs and embedded with us. And she guides our research priorities. She guides our day-to-day procedures. She guides our research procedures. She makes sure that the perspective of the community health centers and the Primary Care Association is constantly right beside us, guiding our actions. We also make sure that we share resources and data whenever possible when we're conducting these projects. So a couple of the projects that I'm going to talk about today, when we're evaluating them, we're using existing data sources. So we're trying to capitalize on electronic health records, on vaccination registries, on other sources of information, quit lines, so that we're not adding an undue burden to our partners. And then when possible, we try to close that loop of information so that our community health center partners are also increasing their access to this readily available data. We also have focused on sharing resources such as grant funding. So that's included when we've gotten, for example, the Footsmart project I'm going to talk about today, it focuses on tobacco cessation. When that was funded, the Department of Health was able to shift some of the resources that they were previously focusing on that our research project was now going to cover and use it for other priorities. So in this example, they shifted that funding to cover medication, cessation medication for the uninsured. And then we also, when we do conduct projects, we make sure to share as much project funding as we can with our partners because they're the ones who are doing the big work. Another key component of all of the projects that we focus on is designing for sustainability. So a lot of our interventions use digital health as a foundation. So that includes electronic health records, population health management tools, text messaging, phone calls. These are interventions that are already in existence and then can be sustained after the project is done. We also use a lot of our interventions focus on using patient navigation. And so to conduct the patient navigation, we use patient navigators that are already existing either in the health centers or at the primary care association. And we really focus on using existing evidence-based interventions and resources. So for example, foot lines are free evidence-based tobacco cessation treatment. So that's a focus of one of our projects. We're trying to have evidence-based interventions that can be used after the project funds are done. So as a result of this partnership process that we built in Utah, we now have multiple funded projects. 6 of them are funded currently with the Utah CHCs and the Primary Care Association and the Department of Health and Human Services. And as you can see on the slide here, they range through a variety of topics. So I'm going to talk to you about the Footsmart Utah, which is the tobacco project, as well as the colorectal cancer screening project today. We also have projects focused on non-opioid pain management, HPV vaccination, addressing COVID-19 testing and screening, and then also lifestyle behavior change programs like the diabetes prevention program. And importantly, all of these project topics were determined by the priorities of our partners. So that's how our partnership approach has led us to making sure that we are having projects that matter to our community partners and allowed us to have sustained funding for this partnership. Okay, any questions about the partnership approach before I move on? No? Okay, great. So the first project that I'm going to go through today is called Footsmart Utah. And the focus of Footsmart Utah is to try to improve access to tobacco cessation evidence-based treatment for community health center patients. And the talks earlier today really gave me a good background for this topic of conversation. As Joe mentioned, tobacco use is a leading preventable cause of death and disability in the United States, has a causal role in over 17 different types of cancers, and it's responsible for almost 1/3 of all cancer deaths. Yet it's still highly prevalent in the US, so 1 out of every 6 US adults currently smokes. We have seen a decrease in tobacco use across time, as Joe has pointed out for Wyoming as well, but we are seeing it become more concentrated in populations that have low socioeconomic status and in some racial ethnic minority populations. So I pulled some data for Utah. So this was from the 2020, I believe, BRFSS. So you can see that in populations that have an income less than $25,000 annually, our current smoking rate is about 19% versus the average of the population of Utah is about 8%. So you can see that tobacco use is concentrated among populations that have lower socioeconomic status. Fortunately, most people who use tobacco want to quit. Approximately 70% of all people who use tobacco want to quit, and almost half of them try to quit each year. Unfortunately, less than 5% of those quit attempts are actually successful, and that's in part because many of them don't use evidence-based cessation resources. So one evidence-based intervention we know works for tobacco cessation is quit lines. So quit lines were first started around the 1980s as a telephone-based quit line that offers cessation services, and they're now available in all 50 states. And they're increasingly being used not only via telephone, but there are online web resources like web chats or having text message conversations with your quit coach. And they've been supported extensively by research to be effective in helping people quit using tobacco. And because of their modality being offered over the phone and online, they have a huge reach. So 95% of US households have some form of telephone services that can access these quit lines. And because of the way that the intervention is delivered, it can overcome a lot of the barriers that people often have for engaging in evidence-based treatment, such as taking the time to travel to some place to do the treatment. And these barriers are often more common in populations where tobacco is more concentrated. So the problem is that even though they're convenient and they're cost effective, quit lines are grossly underutilized and they only reach about 1 to 2% of tobacco users each year. So there's a potential where we can increase the reach of this free evidence-based tobacco cessation treatment to help people quit using tobacco. So the Centers for Disease Control and Prevention and others have recognized that healthcare settings are one avenue that we could partner with to try to increase the reach of tobacco cessation quit lines. Almost 80% of people who smoke see a primary care provider at least once per year. And healthcare systems also already have an infrastructure to address things like lifestyle and behavior change and tobacco cessation. Fortunately, we know that tobacco assessment, tobacco integration with evidence-based treatment is not well integrated in healthcare systems. And part of that problem is because there's a lot of time barriers that come with having to address tobacco treatment during the healthcare visit. There's lots of competing demands. We heard lots about how screening is very important among the other things that primary care physicians have to address with people who come into clinical encounters. And one option that we can try to take that load off of the clinicians is actually referring people to evidence-based treatment via quit lines. But right now we know that referral to quit lines is not great happening in the clinical encounter. And even when people are referred to the quit line, a lot of them don't actually follow through and convert or enroll in the quit line following the clinical encounter. So our approach to try to combat some of those barriers is called Ask, Advise, Connect. Ask, Advise, Connect is an EHR-based intervention that comes up in the clinical decision support in the electronic health record. And it prompts clinic practice team members to ask every patient about their tobacco use, advise patients who use tobacco to quit with just a really quick script, and then implement an electronic referral to directly connect the patient with the quit line. So our approach, Ask, Advise, Connect, has been tested in numerous randomized control trials, including one with community health centers in Texas. So Dr. Wetter, who is the director for the Center for Health Outcomes and Population Equity, used to be in Texas, and he tested this approach there, where he compared the usual care at the time for advising and referring patients to the quit line, which was called Ask, Advise, Refer, to this new approach called Ask, Advise, Connect. So the main difference between the two, Ask, Advise, Refer and Ask, Advise, Connect, is that in Ask, Advise, Connect, the provider can directly send an electronic referral to the quit line on behalf of the patient. So typically in Ask, Advise, Refer, your provider may say, quitting tobacco is good for your health. Here's the phone number for the quit line. You should go call the quit line. Well, that puts the onus on one, the provider to remember to do that, and two, the onus on the patient to actually go home and call the quit line. So the electronic referral tries to eliminate that barrier by having the connection to the quit line sent via the EHR. In some EHRs, it's as simple as 2 clicks. In others, it's a bit more complicated. But then the quit line proactively calls the patient. So the patient doesn't have to remember to call the quit line because the quit line will be calling them. So we tested this approach in this randomized control trial with the primary outcome of enrollment in quit line treatment. And we found that overwhelmingly, Ask, Advise, Connect was more successful in helping patients enroll in the quit line. So in Ask, Advise, Refer clinics, only about 0.5% of all patients who came in that used tobacco ended up enrolling in the quit line, whereas in Ask, Advise, Connect clinics, almost 15% of patients ultimately enrolled in the quit line. So that's a 29-fold increase in quit line enrollment using the old method of Ask, Advise, Refer versus this new method of Ask, Advise, Connect. Okay, so that's a huge increase, 29-fold, but it's still only 15% of patients who use tobacco that ultimately enrolled in the foot line. So our next thought was, okay, so what can we do to increase engagement in the foot line even more? So key findings from our previous research, we know that Ask Advise Connect works, and that it leads to this 15 to 30-fold increase in foot line enrollment versus referral programs alone. And actually the Ask Advise Connect is a CDC nationally recommended standard now. So it is also an evidence-based intervention to try to increase reach of foot lines. From our previous work, we also know that repeated offers of treatment works. So motivation to quit using tobacco waxes and wanes over time. We see this very dynamic change in motivation among patients over time who want to quit. And among those who are offered repeated opportunities, our research has shown that just offering repeated times increases enrollment in the foot line, even if they were initially unmotivated to quit. And then our other research has shown that using counseling and patient navigation can work even among patients who are unmotivated to quit using tobacco. So we know all of these things work, but we are not entirely sure of what works for whom and how much help does any individual person need. So that's where Footsmart Utah was born. The goal of the project is to save lives and reduce suffering by helping more people quit using tobacco. And in this project, we're testing 3 different strategies to try to increase enrollment with the foot line. Clinic level intervention, Ask Advise Connect, which I already described. We're using text messaging, so patients receive brief text messages with a motivational message and an offer to enroll in the foot line. And then we're also using an approach called motivation and problem solving via brief telephone calls. And that approach basically takes motivational interviewing and adds on some components around how do you address practical problems and barriers that a patient may have. And it focuses on meeting patients where they're at to address their specific barriers. This is it was originally a 5-year pragmatic clinical trial, but as you know, this thing called COVID happened. So we're now, I think, going into 6.5-year project on this one. And it's funded by the Patient-Centered Outcomes Research Institute. And with this project, we're again partnering with the CHCs that I described earlier and the Primary Care Association. And we're working with 10 different CHCs throughout Utah and 32 total clinics in Utah. Our study design for the project is somewhat complicated. It's called a sequential multiple assignment randomized trial, or a SMART design. Basically, it's trying to test how much of an intervention someone needs, and do we need to increase our care, increase our amount of intervention someone gets, or change the type of intervention that they're getting across time. So it starts out with the least intensive intervention and oftentimes the least expensive intervention. So in our project, that's Ask Advise Connect, the intervention that we know works to get someone connected to the foot line. So a patient comes into their clinical encounter, they get offered the connection to the foot line. If they enroll in the foot line, that's great. We've achieved our outcome. We don't need to do anything else for that patient. They're done. If they don't enroll in the foot line following the clinical encounter, they're then randomized to receive those brief text messages or to a control condition. So the text messages, they're sent once a month. They go on for 6 months. They basically just provide additional opportunities for the patient to enroll. And the patient can enroll by replying to the text message, yes, enroll me, or they can click the phone number and be taken directly to the foot line, or they can click the foot line website. So we're just trying to make it as easy as possible to get someone to the foot line. If after 6 months of receiving text messages, the patient still doesn't enroll in the foot line, then they're re-randomized, this time to receive continued text messages. So again, those monthly text messages, plus the addition of 2 brief health coach phone calls using the MAPS approach. And at the end of 12 months, we'll assess what their abstinence status is, as well as if they engage in foot line enrollment. So basically, the whole point of this phasing of interventions is to try to test the most minimal intervention first. And then for those who don't respond to that intervention, then we can start increasing the amount of care. And as you can see, we start with electronic health records, the least intensive intervention, go to text messaging, which are still very cost-effective, low contact interventions. And then finally, we bump it up to the most intensive intervention, which is actually having someone call the patient to address their motivation and barriers to enrollment. So we have about a year and a half remaining in the Footsmart Utah project. So far, we have e-referral implemented in all 10 of the CHCs, so that's 32 clinics and 10 community health centers. We've had around 7,000 patients that have been randomized to text messaging, and among those, about 1,200 that have actually started to receive health coach calls. And I am not allowed to share our outcomes yet until the end of the project, but we are seeing some promising results for the number of people who are getting enrolled in the Footsmart. So that's very exciting. Okay, so that's the Footsmart Utah project. I have one more project that I'm going to go through really briefly, and then I'll move on to some lessons learned in future directions. So the other project I'm going to talk about today is the Utah Colorectal Cancer Control Program. So similar to Footsmart Utah, the goal of this program is to try to increase the implementation of evidence-based interventions that we know work to help increase in the colorectal cancer screening rate among community health center patients. This one's a little different in that each community health center gets to pick which evidence-based intervention they want to implement. So I have the three different interventions listed here. So we have provider reminders. So again, having an electronic health record-based reminder to say that someone is eligible for colorectal cancer screening and prompting the provider to recommend it. A client reminder, which is basically a patient reminder. So sending things like text messages or mailers to say you're eligible for your screening and helping them get connected to screening. And then provider assessment and feedback, which is where we take the colorectal cancer screening rates, aggregate them, and then feed them back to clinics and providers so they can see how they're doing throughout the program. And so in this approach, each of the CHCs get to pick which intervention they think is most appropriate for their health systems or a combination of interventions. So right now we have 8 health centers that are participating with a total of 25 clinics. In addition to the evidence-based interventions in that black box, we also have patient navigation for those who need follow-up for diagnoses through an electronic referral. We're also implementing an Azara referral module. So Azara is a population health management tool that the community health centers have all signed on for. And this module helps to create a system where it's easier to identify those people who are needing screening, need to be up to date for their screening, and then to use a campaign, as they call it, to send out text message reminders at a certain time interval to remind patients if they're ready for their screening. And then we've also implemented a return fit APO, which is essentially another form of a campaign to remind patients to return the fit after they have a fit. And we're seeing some promising results with that intervention as well. So some underlying themes for how we conduct these projects. So we're really focused on this community engaged dissemination and implementation research. So for our project partners, we have the University of Utah and other academic research centers. We work closely with the Primary Care Association, who's been critical to helping us create inroads with all the community health centers. We work directly with each of the community health centers. And then we also work with the State Department of Health. And I already briefly described our key partnership characteristics, but I want to just touch on our key engagement activities a little further. I think these activities are partially why our projects have been successful and why we've been able to leverage this infrastructure for more funding. So as I mentioned, we created a patient and study advisory committee. We just had one of these 3 or 4 days ago, where basically we come to this group that consists of representatives from each of the participating community health centers. So we have clinic managers and NA managers and quality improvement folks and physicians, nurses, all who sit on this board. And we essentially pick their brain for what's going well in ongoing projects, what the plans are for the next steps in those ongoing projects, and then we seek their feedback on the actual interventions we have. So one example, at the very beginning of the Footsmart Utah project, we were working through the electronic health record, trying to figure out what should the statement be that comes up as the advice when a patient is seen and they use tobacco. And our original statement was something like, quitting tobacco is the best thing you can do for your health. Do I have your permission to send a referral? And the patient representatives told us, no, we don't want that. We know that quitting tobacco is good for our health. This is not helpful for us in any way, shape, or form. And they recommended that we include more information about what the Footline actually offers. And so now our statement indicates that anyone, regardless of insurance status, can get free nicotine replacement therapy. They can get free health coaching, and that the quit line will proactively call them. And so this not only helped the patients by what they wanted to see, but we also heard from our clinic representatives that they really didn't know that much about the quit line either. So it was an easy way to provide the information that patients wanted to hear in the intervention. So that's just one example of how we've been able to tailor our interventions to make sure that they're meeting the populations who will actually be getting the interventions. We also do clinical workflow analyses and usability assessments for all of our interventions. So for the clinical decision support interventions, or the ones that are in the electronic health record, that means actually going in and observing a routine clinical workflow to see who does what to address tobacco use and when does it happen, and how do they interact with the EHR. And then the EHR changes are designed to be as minimally disruptive as they can be to what's going on in that clinical encounter. And so we do those observations, we come up with a prototype of what the electronic health record would look like, and then we feed that back to the medical assistants, the providers, whoever's the one that's going to be interfacing with the actual EHR. So that helps us to make sure that it's designed to be a useful tool instead of an annoying tool that everyone just wants to get rid of. I'm seeing the oncologist in the room. And then, as I mentioned, we make these adaptations throughout the project to our implementation or interventions. And this ensures that we're still doing the science that is going to lead to a generalizable impact, but we're able to adapt it to something that's useful and helpful based on what our community partners told us. Okay, some lessons learned. So throughout these projects, we've learned how critical it is to have that embedded CHC liaison and the bridging capacity between the CHCs. I think we figured this out more during COVID than anything else, because we had our community liaison, our CHC liaison, who was there telling us what the capacity was of the CHC, what was going well, what wasn't going well. When they were too busy to tell us about it, they were too busy to do anything but essentially survive. We also learned that the partnership is key to overcome challenges related to not only implementing interventions, but also conducting the research side of things. So one example is that in order to conduct the projects, we actually had to go through multiple different IRBs related to the University of Utah Institutional Review Board. Sorry, the IRB is an institutional review board that essentially governs the research process to make sure that the work that you're doing is protecting every individual's privacy, confidentiality, that you're not doing any harm to individuals. And we've had to get institutional review board approval from the University of Utah, from different tribal organizations that we're working with, and the Department of Health. And so our partners were able to help us overcome understanding the logistical processes that go along with that. We've also found it incredibly important to include diverse perspectives to advance health equity. So the example that I gave previously about emphasizing that free was something that we've heard across all of our projects. So free tobacco cessation resources via the quit line. We have a COVID project that's trying to increase the use of free at-home COVID tests. And again, they told us use free in the language so that people know it's free. So we've been able to tweak our interventions based on different perspectives. And then we've also been really focused on designing for sustainability. So not only are the individual interventions we developed, are we designing to be sustainable, such as an EHR change that is still there after the project's done, but we're also really focused on building this partnership infrastructure that we can use to leverage for more funding and more projects, which then in turn leads to more funding to support the partnership. So those are really key lessons that we've learned. Okay, so for future directions, we're really focused on developing partnerships in the Mountain West. So I have some other folks from HCI here, Melissa and Nathaniel, who are also with HCI focused on community engagement. So if you have any more questions about this presentation or anything else that's happening in the Mountain West with HCI, I invite you to ask them questions as well. So as you all may have heard, the Huntsman Cancer Institute has expanded the area that we serve to include all 5 Mountain West states, which is really exciting. And we've also been conducting projects with a number of Mountain West states throughout the last, I think, 3 years or so that these have been ongoing. And one of them is the Mountain West HPV vaccination project. So that's in conjunction with ACS. We're running that project, and Melissa is actually one of the people running it, so she's the most knowledgeable one on this project. But we have all 5 Mountain West states who are collaborating on this project. And again, we're taking that approach of trying to implement evidence-based interventions to improve HPV vaccination, and clinics who are participating get to pick which evidence-based interventions make the most sense for them. We also have a project that we conducted focusing on survivorship in Montana that was conducted with the One Health Community Health Center. And we also have a project for implementing Ask Advise Connect in Nevada with a community health center in Nevada. So looking forward, we're really excited at the opportunity to build more partnerships in the Mountain West. And it's been incredibly exciting to hear about all the good work that you all are undertaking as part of this coalition, and also to hear some of the data that Joe presented to see where your priority areas are, in addition to your state cancer plan. So we're really excited to continue to expand our portfolio of different digital health and telehealth initiatives. And we're really focused on expanding partnerships in the Mountain West among academic institutions, among community health centers, primary care associations, state health departments. We have a number of UHealth clinics, UHealth affiliates, HCI affiliates, Intermountain Healthcare, and other healthcare systems in the Mountain West that we're excited to partner with. And overall, we want to continue to design and implement and evaluate interventions that can be used at a broad scale to improve implementation and dissemination, as well as improve health inequities in the Mountain West. And that is a picture of a member of the Center for Hope team. We had to get creative with our COVID team pictures. And with that, I will finish up. Thank you. Are there any questions?
If you have questions, can you come speak up here so that the online attendees can hear? Thank you. Yeah, you have to be close to the.
Yeah, I think
You're good.
Okay, hopefully this works.
I come in the video if you want.
I'm good. I just wondered if you could speak to any projects you guys might have planned with your affiliates in Wyoming, if there are any specific things going on with those.
That's a great question that I'm going to punt to the back table. Who may know more specifically about this or may not. Stephanie. Stephanie is one of our affiliates in Sweetwater, I believe. Yes.
I'm sorry, the microphone apparently isn't resonating on the computer.
I don't really know too much about the exact affiliation because we've been affiliated for quite a while. But I haven't been in a lot of the meetings yet.
Yeah.
Is Tasha still online? I think
Tasha, are you still online? Lacey, can you say something if Tasha isn't?
I have a couple things I can add. So we have at the Center for Hope, we have a couple of positions that their entire position is essentially to do community engagement and help us build partnerships and understand partner priorities, and to essentially bring that knowledge back to the research institution and find researchers who can help partner to address those priorities. And so we have one team member on our team, Kara, who focuses on the affiliates, and she's not here with us today, but I know that she in the last year has been building lots more partnerships with the affiliates. And I apologize, I don't have a better answer for you all. It looks like Daniel has some information.
Well, one great program that we have in Wyoming that's very specific to Wyoming, we recently received grant funding from the American Cancer Society to do patient navigation. And so we're running a rural focused patient navigation program through our affiliate sites in Wyoming and Montana. And so for Wyoming, that includes 2 sites, which is Sweetwater and then also St. John's. And so that'll be a great collaboration as we look at if we need to kind of coordinate that care when they need higher acuity or more specialized care and they have to come to Salt Lake, but then closing that loop back to Wyoming. So, they get in contact with their local oncologist, their local primary care provider, and local resources as to make sure that their survivorship plan moving forward is going well. And so that is very new. We are just hiring our rural navigator, and that seems to be a really good project over the next 3 years, and then hopefully continue that centrally funded. So that's like an example of maybe one. Yeah. And so there's a tag to that kind of like what we discussed here, a lot of electronic health record optimization and looking at those kind of care coordination and how we can help, make sure that the care is being taken care of at home and close to home, but when they need something specialized, we can do that, but also keep that loop tied and keep that going. Yeah.
It was also mentioned that Sweetwater has a grant to house patients to come be seen in Salt Lake City.
First of all, that is great work. I mean, this is really high impact stuff. And this is where the rubber meets the road and people lives are really improved. So thank you. And anybody, especially on the prevention or, screening groups, this is the sort of stuff that can really make headway. And so my compliments to you and your team. What happens after the study's done? So a lot of this is done in the context of a grant that's supporting an academic study, and then you get conclusions and you can say, yes, this intervention worked. And then, I'm assuming you don't just pack up at the end of the study and leave and just say this is, or how do you promote longevity for the study findings?
That is a great question, and something that's always on our mind when we are trying to understand priorities and come up with interventions that we can work together on. So I'll take the Footsmart Utah project as an example. So the electronic health record, the EHR-based change that we made, that will exist after we're gone. So we built the connection to the quit line. The quit line is an externally funded by the Department of Health and Human Services at Utah, available to everyone, regardless of whether the study is ongoing or not. The EHR-based change will be there, regardless of whether we're there or not. And we have lots of ongoing projects with the Utah CHCs. And even if something breaks in the health record, we have someone on our team who actually used to work with EHRs at the CHCs, and so knows how to fix those. And so even if the project isn't being funded currently, we've helped them out with just changes they need with their EHR. So we try to focus on what interventions are going to be there and can be sustained after we leave. So the EHR is one of them. The text messaging. So part of the reason we chose text messaging was, one, because it has this huge reach, it can reach a lot of people. Most people have text messaging enabled on their phones now, but also the CHCs purchased this population health management tool that allows them to do texting campaigns. So if at the end of the study, we find that this frequency of text messages with this content is the one that seemed to work the best, they can then implement that in their already existing texting infrastructure. And even for those who don't have a population health management platform, many of them do use texting for things like reminding patients about appointments. Some are using them for colorectal cancer screening. So that's something that they could easily take and then use in their health system. And then the patient navigation and the maps calling. So the interesting part about that is that we've actually gone to using community health center and primary care association patient navigators. And so they're trained in this approach that they are now using across a wide range of behaviors. So we won't have the funding to continue to fund them off of this project, but we're hopeful that that's an approach that they can take and use with their existing patient navigators. And I am so excited to hear about all of your priorities. That's one of the exciting things about being here, is really understanding where do you guys want to move forward with addressing priorities for cancer in your state. So excited to be here and to start addressing some of these priorities.
Any other questions? Is there questions online, Randy?